All right. Welcome, welcome. So this is the next in our conversations series, which is working with the idea that as homeopaths, we were just born as people, and we didn't actually come pre-equipped to talk about all kinds of awkward things. You know, I don't know about you guys, but the first time, do you remember the very first time that you read through the rectum series section of the repertory, or maybe the chest section, and everything that you learned about sputum or stool? Or it was like every conversation I had never wanted to have about anything was all right there. And as healthcare practitioners, we got to go there. We got to be willing to have awkward, difficult, challenging conversations with people who are suffering and who are in pain. And so we've been working our way up to some of the more challenging conversations. And today we're going to be talking about trauma. And we're going to talk about this in the context both of how do we inquire, how do we think about this, how do we hold it, and how do we disperse it. Now, if you think about it, somebody comes to us in a broken place, and then we find a way to navigate that with them. And one of the challenges of working with broken people is sometimes broken people lash out and attack us. We talked about that in some of the earlier sessions. And also sometimes there is a burden for us just in looking at ugly things, listening to ugly stories, hearing difficult, painful stuff. So let's just start right there. Before you became a homeopath, did you have the idea that you were going to be listening to pain in terms of somebody sharing a story of a death, of sharing a story of a trauma, of a rape, of a car accident where they felt their bone break? Have any of you guys had an experience where you sat with someone who described a painful event and it felt maybe, overwhelming, or wow, I had no idea I would ever be listening to this? Let's just start with getting real about who we are as practitioners and what pours into our ears and eyes and skin as we are present with this client, with these clients. Is it just me? Am I the only one who talks to these people? So if you think back to the first couple of clients that you had where you were really surprised or stunned, how did you react? Myra says she can listen to it. You know, Myra's a practitioner with a lot of experience. She's been working for a long time. But she says, I can't see it. I was in the ER and there was a man who had his hand cut off in a machine, with a limb and eye, screaming and writhing in agony, and they seated you opposite him, and I couldn't stand it. I thought I would faint, but I would be able to hear his story after the fact. Yeah. That's a pretty brutal thing to sit with, isn't it? Deb says, I've always been drawn to people who are suffering or going through something painful. So was there a time, Deb, for you where somebody told you a story? You know, there are many of us as practitioners where we absolutely are drawn to where we can comfort. And sometimes I think in that desire to comfort, we bite off more than we can chew. So I can remember the first time this happened for me in my practice, where I had an experience that felt like sitting across from the person with their hand cut off. A woman came in and she told me about her baby who had died. And some of you who have done a lot of training with me may have heard this story before. She was carrying in groceries from the car, and she had her baby who was, I don't know, 12 or 15 months old maybe. And she sat him down in the trunk. And he was sitting there. She was kind of rearranging some things in different bags and getting the bags out. And she took some bags out and turned to sit them on the sidewalk or the driveway or whatever. And as she turned, the little baby was going to come out, and the trunk lid closed and decapitated the child. Now, there's nothing in our lives that prepares us for that. I had another woman whose baby strangled in the cord for the curtains that were by the crib. Now, I can listen to and be present with all kinds of other things, but I can't listen to and be present and work with clients who have domestic violence or especially domestic violence that involves children. I can't do those cases. I don't have that kind of boundary, and I can't. It breaks me. So the first thing that yeah, Rachel says that she had a client who accidentally ran over their toddler. These things are real and they happen. Mm. Oh, Myra said she was told how, as a little girl, their mother told her to say her father was her uncle and her uncle was her father. And that was upsetting. There's all kinds of things that we are going to experience. And one of the things between being a homeopath, which means I can elicit symptoms, I can repertorize, I can differentiate, I can select a homeopathic remedy, and being a practitioner, which means I have the capacity to engage this client in many different ways and to have good, appropriate self-care while I'm doing it. These are different things. These are fundamentally different things. Deb says, what would be hard for me would be to work with someone who inflicts pain or trauma on someone else. So early in my practice, I worked with some clients who were sex offenders who told me about torture, sexual torture, and all kinds of sadism things. And some of them you could see that they were gleeful about having inflicted this pain. That's the pathology of sadism. And they could feel how uncomfortable I was. And they were inflicting that pain again by telling it. Have any of you guys had the experience of talking with a client where they are describing their trauma, their personal trauma, in incredible detail and pausing for effect here and there as if they know that their story is likely to upset you? Yes, and enjoying it. There are people who take joy in other people's pain, and there are people who take joy in their own pain. Yes. And that's what really sick people do. So hopefully we don't end up with a lot of those in our practice, because there's a wear and tear associated with that. We have to find a way to make peace with the fact that pain exists in the world. Pain exists in the world. And if we were just in a Startup to Stellar session where we talked about Martin Buber and the idea of relationships between two people of I, thou, or I, it. When someone is inflicting pain on someone else, that else is an it. It's an object, not a person. When we look at someone and say, oh, and we see them as a victim, we are objectifying them. They are becoming the inflicted wound instead of an amazing person who has that wound. I'm going to say that again because I want us to establish that groundwork before we do anything else. It'll help us all stay in the room while we talk about this. The client that we see as broken, as the pathology of victim, where we think of them as a rape victim or an abuse victim or a domestic violence victim or a war tragedy victim or a victim of circumstance or a victim of a car accident or a victim of whatever it is, we are seeing them as a broken it. We are not seeing them as a person. And it will change the way that we interact with them, and it'll change the way that they interact with us. So, early on in your practice, you've got to find a way to get right with pain, to accept that pain is part of the human experience. And for some reason, the human psyche uses it as a whetstone. Now, there will come, hopefully, a time in your practice where instead of looking at someone and seeing them as a broken it, you look at them and you say, oh my goodness, look at the nobility of the human spirit shining right there at me out of this person's eyes. Look at this person who has had all this amazing, bizarre stuff happen to them, who still gets up in the morning and puts on his or her socks and shoes and isn't addicted to any controlled substances and goes about and tries to heal. Look at the wonder, the miracle of this person who is coming to see me, who is looking for healing even in the face of all of this pain and misery and difficulty. Still stubbornly, the human, noble human spark inside this person is still bright. It's still alive. They're still seeking to heal. When you see that, you see the person. When you see that, you will never see them as a victim. Yeah, Deb says, I know that a horrible thing only happens to an amazingly strong person. And the more horrible, the stronger and more amazing. Yes, which is why that bright spark is able to stay there in the face of all those difficulties. Okay, so we've laid our groundwork with the intention. I just want you to take a minute to set an intention that everybody that you talk to with trauma, that you will see in them the spark of their human desire to heal instead of seeing a broken it. Can you take a moment, just close your eyes and set that intention right now for the entire rest of your practice, the entire rest of your professional life? Okay. So, are you guys familiar with that Leonard Cohen song? You know, that the broken places are where the light comes in. So, trauma is the broken places where the dark seeps out and the light comes in. So, We came to this profession from a lot of different backgrounds. We've got to communicate with clients effectively. School programs, a lot of them don't have very much training about how do we navigate pain. And our effective communication about it can make or break our practice, especially depending on what it is we're doing. So today we're on number 7, eliciting information safely for trauma. So conversations, talking about trauma with our clients. Trauma happens for us, for them, for everybody. It happens. And we want to be able to be present and make peace with pain. And to the extent that we can't make peace with it, then being present with it creates stress for us. So when we work with these clients, we have to be aware that trauma is processed differently in the psyche and in the body. And a lot of trauma stays in the body for a very, very, very long time. And as we inquire about things, we can run into old traumas that we don't even know are there, that the client has covered over, that can kind of pop up and be a problem. When we are inquiring, we can re-injure. Have you ever had the experience? I've had this experience where you're talking with a client and you just feel like they are so guarded that you can't get the information that you need to take the case. Have you ever had that happen? I had one client where I felt like she was just so careful and hesitant about every single thing she said that I couldn't really get any symptoms. And I finally thought, I just have to put this on the table as a topic. And I said, I just want to check in with you. It seems like you're quite guarded and careful about what you're saying. And I'm wondering if you're feeling hesitant about sharing anything with me. And she said, actually, I thought I was being extremely open with you. And I thought, wow, I don't know that I know how to take this case. We had one intake and we had one follow-up, and it became very clear that she just wasn't a good candidate for homeopathy. I just couldn't, I still don't understand what was going on with her. So there are times when people are incredibly guarded about what they say to us. And there are also times where we think, I don't have enough information. And it's like we will kind of want to pull more out of the client. And in a way, this is kind of disrespectful of their process. We have to be very careful to allow people to open up to us instead of trying to crowbar information out of them. And especially when they have trauma history. And a lot of times, guys, we won't know until it blows up. So some of you may have had the experience of some kind of past trauma where you had a trigger and you relived it. I had that experience. I was raped as a child. I knew that it had happened. It lived kind of over there. I was threatened, if you ever tell about this, I'll kill you. It was kind of that kind of a scenario. And so I never told anyone. I never told anyone until I was 50. And I had, this was 12 years ago, and I had recently been studying about the remedy chlamydia. And I had ordered it in high potency and was dispensing some of it for a client. And of course, when you dispense, you get a dose. And the next day, I had someone I'd been seeing for a long time, and he and I were in bed, intimate, and I relived the whole rape. Now, those kinds of events of a traumatic thing that sat over here sometimes can be re-engaged. And what we want to be sure of, and what I'm going to teach today, is a method of preventing us from accidentally re-engaging those things by an insensitive method of inquiry. Okay? So we should know, what can we expect to happen in an interview? What can we expect to happen as a resolution? And we need to learn a very respectful style of inquiry, a style of engagement. Okay, are we all still in the room? Everybody okay? So, who is impacted by trauma? We've had a couple of these examples already. Those who experienced it, the case that Myra gave earlier, and Myra, I'm so sorry you had to go through that. Those who witness it, and also sometimes those who create it, who might have flashbacks or remorse or whatever. All of those people. And we deal as practitioners with acute trauma, which is very recent, not part of the chronic state, likely to respond to different remedies, and very high reactivity, very urgent. There's an urgency of disruption for these clients. And then chronic trauma, we deal with things like my experience that I had had in a child that had been quiet and over there for a long time and was not well integrated into myself. And that gives us this risk of accidentally stepping on landmines with clients. Have any of you guys had the experience of stepping on a landmine with a client? You think you're asking an innocent question, and all of a sudden, kaboom, they are angry, or they burst into sobs and fall apart, or they have a huge out of proportion reaction to what you thought was a simple generic question. Have any of you guys had this experience? Myra has, Jiwan has. Yeah. Okay. So what are the types of trauma that we are likely to see? We're going to see basic violence, sexual assault. For those of, most of our clients are women. And according to the World Health Organization, in their research, about 40% of women have had some sort of molestation, sexual aggression, all the way up to rape kind of action. So we can assume that 4 out of 10 of the clients that we see will have had some sort of experience like this. If you have your own personal history around this that is unfinished and incomplete and uncomfortable, then you have work to do. You need to get yourself clear so that you can be present, or you need to be very clear that you are not working with those kinds of clients, because you do not want to re-injure that vulnerable part of yourself, and you also don't want to be unavailable for your clients because you've left the planet while they're busy talking. There's also neglect of abuse, trauma of abuse, trauma of neglect, trauma of all kinds of inappropriate interactions. It can be verbal, physical, experiential, people who are in a war zone, people who have an inherited family experience, someone whose parents were in a refugee camp, someone who was raped in a refugee camp and then has a child where they have inherently mixed feelings about that child. Social experiences that we have, like everybody who watched that plane fly into the Twin Towers again and again and again on CNN on 9/11. There's some very interesting studies that have been done about the level of trauma that created for a populace by witnessing that image again and again and again. Do any of you guys remember that? Watching that on TV? I'm not a TV owner. I think I saw it once, maybe online. But there were a lot of people, and my clients certainly told me about it. And even more recently, how many of you had clients who talked to you about the Supreme Court judge hearings and about the sexual abuse history and the report For your clients who had sexual abuse histories, were they triggered by that? What was that, last August? Yeah. So this is in the milieu of what we do. And unless we get comfortable with it, we are going to be practicing one arm behind our back. And we better focus on something like tennis elbow, or, some musculoskeletal thing, back pain. You could have a whole practice on arthritis for elders and never have to talk about any of this. And that would be fine. But if you are going to do a general practice and meet people in the places where they are broken and help them find where the light has come in, then you have to be able to engage in this way. So we spend time with pain every day, every week. How high is your own personal pain tolerance? Ask yourself. Low, medium, high? What are your coping strategies when somebody comes in? Can you imagine the experience of being a client? And maybe some of you have had this experience where you come in and you bring your difficult experience into a practitioner. And as you tell them whatever your traumatic thing is, you see on their face, they can't handle it. You don't ever want your clients to have that happen. Can you imagine the feeling there of, oh, wow, I'm so broken that this therapist can't handle what happened to me? So let's not go there. What are your coping strategies? Do you go into shock? Do you dissociate? Do you see the person as a victim, as an it? Do you stop being in the I, thou place and go to the I, it place? Or do you over-identify? Do you all of a sudden dissolve into their experience and you feel their pain long after the consult is over? And there you are, 3 o'clock in the morning. Oh my God. Can you believe what happened to that person? Does that happen to you guys? I've been there. There are times when I sit on the floor and sob. Not so much now. It used to happen much more often, but it still happens. Usually around a pregnancy loss. So we can over-identify, we can go into misery and depression, and then we can come up with all kinds of compensatory things. Wine, women, song, cocaine. I don't know. Some sort of methodology to help try and make us feel better. So I want you to ask yourself right now what your own coping strategy is with pain. Don't write it in here. Just ask yourself right now, when I am faced with overwhelming pain, how do I deal with that? And I want you to think about this both in the acute instant. There's a lot of people who are great in the instant. They're Herculean, they show up, they're professional. What about when it becomes chronic? What about when it's not just today listening to this person's pain? What about when it's all week, every week, for months and for years? For me, when I was early on in my practice and I was listening to all these really horrible stories of sexual offenders and abuse, and it was so ugly, and I began to dread going into my office. I was not able to get myself out of the place where I thought, oh my God, life is suffering. That's all it is. Life equals suffering. That is a distorted view. That is where my identification is completely with the victim instead of with the nobility of the human spirit. So our homework as practitioners, our inner work, is to actually acknowledge the role that pain has in refining the human spirit. that humans, for whatever reason, seem to use this as a way to evolve, as a way to learn, as a way to deepen. So, talking with clients about trauma. I'm going to make these documents available for download from the Trinity Health Hub, so you guys will be able to go out and find them there. We're going to go through the guidelines for interview from this organization. I want you to print this, and then let's stop this share here and let me go grab this other item. Okay. Are any of you guys familiar with the FETI methodology? So this is called a forensic experiential trauma interview. And basically, this is a methodology that is being taught for people who have just witnessed a murder, or just been raped, or just been shot, or, whatever. These are people who are in extreme disruption. And surprisingly, you'll see as we go through the method, so much of it is what we already do as homeopaths, that we're really well equipped to use this methodology. So the first thing is that we meet them where they are. We acknowledge their trauma and pain and stressful situation. And I would suggest that you guys grab this, once I post all this stuff on the Trinity site, or you can actually go out and just Google forensic experiential trauma interview, and you can get the FETI information yourself, but grab this and stick it somewhere in your clinic reference notebook so that if you need it, you can review it. You can have it right there beside you. So the first thing, acknowledge their trauma, their pain, the stressful situation. Wow, I can see this is really a difficult setting. So this is what, if you took the class on counseling that Cambria Lowe and I did, we talked about a strategy called name and explain, where you say what something is and then you tell about it. Wow, this is a really difficult setting. And you just own it. You don't apologize for it. You don't try and reframe it. You just meet the person where they are, which is so fundamentally homeopathic. And then you say, what are you able to tell me about your experience? Right there. What are you able? You don't name the part of the experience you want them to talk about. What are you able to tell me about your experience? And then after they tell you something, you use phrases like tell me more about or help me understand, which we as homeopaths already do. And then instead of going into details where we are picking what we want them to tell us, we drill in a little bit further. What were you feeling when this happened for you? What was your thought process during this experience? And then we go into the sensory things. What are you able to remember about? And for many people in a trauma experience, their brain shuts down and they remember it through their senses. So people will say, I could hear the sound of the glass breaking. That's really all I can remember. And so you just stay right there with them. Tell me about the sound of the glass breaking. Where did you, as you think about that, where do you feel it in your body? What were your reactions to this experience physically and emotionally? And then you help them, often I will say to clients, the actual event that happened doesn't help me very much, but the way that it created a reaction within you helps me a lot. So let's talk about what your response to the event was. And I think for a lot of people, when they, especially people who were raped or attacked or mugged or beaten up or something, they don't want to talk about the event. We don't care about the event. The event doesn't matter. The client's adaptation to the event matters. And what I love about this interview technique is that it doesn't ask questions about what happened. It's only about what you experienced. Now, if we ask clients about what happened, we risk the injury of pushing them, like my experience of triggering and reliving. We risk the injury of stepping on a landmine and pushing them back into that. So we want to be, when you say, tell me about your experience of, how did you feel? What were you thinking? What were you able to remember about your senses, smell, taste, touch, feel? All these lift the burden of actually describing the event of, whatever ickiness it was. It could be an animal attack. Okay. And then there's the last question here that I really love. What can't you forget about your experience? And sometimes people will say the smell of the blood. I can't forget that. Or the way that the light was shining on the water. Or the sound of such and so. And this is where we can actually get into where they are stuck. And then you clarify any other details after you've gotten everything you can about what did they experience, where they never have to talk about what the event was. They only have to talk about how they felt it. And these people need to feel safe. And so it's helpful to reassure them, we have plenty of time. This is a confidential, safe place for you to say whatever you need to. And you can give them reassuring messages that help them. Okay? How are you guys doing? Everybody still in the room? If the event was a long time ago, do you ask them how they feel about it now or then or one or the other? I usually ask them how they feel this event has affected them, which invites all time continuum associated with it. Does that help, Deb? Okay. All right. Let's get out of this little diagram, and I'm going to pull up this other document. Again, I will put this on the Trinity website. Okay, are you guys able to see this document by Russell Strand, Forensic Experiential Trauma Interview? It would have helped me a lot in my practice to have seen this in the months before I started working with all of these really serious sex offender cases. And so I think this information is going to help you. So traumatized individuals undergo a process that those of us as practitioners, if we've never been through it, may not understand. And so if you look at the way that the brain manages this, it will help you. Practitioners tend to believe that somebody's going to have an objective view of what happened and be able to report that. And in actuality, look at this little diagram here. When trauma occurs, the prefrontal cortex will frequently shut down, which leaves only the less advanced, our very primitive brainstem parts of ourselves to experience and record the event, which means it can be incredibly difficult to articulate later. Now, when I think back about this woman who couldn't share her experience with me, I think she was in her brainstem. We have to even ask ourselves, is homeopathy, which depends on reported experience, the right discipline for some of these cases? Okay, so collecting information about the event while overlooking the manner in which trauma shapes the memory can actually inhibit traumatic or highly stressful or fearful producing memory recall and accuracy of the details. What this means is that the way that we ask questions can actually make it more difficult for people to talk to us. Trauma victims do not generally experience it the way that we experience a non-traumatic event. So if you think about the last picnic that you went on, who were you with? What kind of day was it? What was the weather like? What did you guys eat? What kind of blanket there was? You're going to remember that completely differently than if there was a forest fire and you were running for your life out of the picnic place. So they have a very specific methodology. I want to encourage you to read this whole document. And one of the challenges that we have as homeopaths is that people, have you had that experience where you ask somebody, is it like this? And they say yes. And then you say, is it like that, which is the opposite of this? And they say yes. And the more somebody is in trauma, the more inconsistent they are likely to be in their report. And this is consistent with traumatic experience. It's not that they're trying to lie to us. So here's the technique. Acknowledge the victim's trauma and or pain. So this is the very first step of establishing trust. And you want to do this, first of all, with your body language. In your office, are you sitting where you're at eye level with this other person? Or are you sitting where you're higher and you're looking down at them? In your office, are you sitting behind a desk as an authority? Or are you sitting in a chair, like in a little V shape or across from them, where you're right there near them? In a trauma case, as much as possible, try to be, to some extent, beside the person. Not above, not behind a desk, not across from. You want to be there beside their trauma bubble. So, you may need to spend additional time establishing empathy and caring concern in order for them to invite you into their trauma bubble, which may take multiple consults. Now, I want you to also think, as you're there with them, you're putting a little rescue remedy in some water and you're giving it to them. I'm thinking right now of one of the first cases where I really was able to effectively do this, and it was a client, a long-term client who had been shot. She'd been standing on a street corner waiting for a bus, and somebody drove by in a car and shot her. And it was a gang-related event that had nothing to do with her, and she got shot. And it completely altered her experience of being safe in the world. Now, you don't, do you know anybody that's personally been shot in gang violence? I don't, except for this one client. And I had to think about, golly, how do we deal with that? And when we had the consult, when she came in, she'd been to the hospital, they'd taken out the bullet, she'd gotten sewn up, and 2 days later, she's there in my office and she's just shattered. Her idea of a reasonable, navigable world is now just gone. And so when she came in and she sat down, I talked about how this is a safe and confidential place, that she can say whatever she needs to. And I gave her some water with Rescue Remedy. And I said, let's just start with taking a few breaths together. Let's just be here. You don't have to say anything. Start when you're ready. Let's just breathe here together. And so one of the best things that we can do is not pressure the person. We may not even want to start with a question, which puts a pressure on them to speak up. As soon as we are aware that this is a trauma scenario, which isn't necessarily at the beginning of the consult, right? It might be something where things are going along fine and all of a sudden you step on a landmine and now we're in the land of trauma and we weren't expecting this. So right there, we can take a breath and say, wow. So it looks like this is a really intense thing. So let's get you some water with some Rescue Remedy in it. And I want you to know I'm here for you. So take whatever time you need. And then you just sit. And whatever way they're breathing, you match their breathing. You just sit with them. And then as they start to talk, whenever that is, you say, what do you remember about your experience? Okay? And then whatever they talk about, they're supposed to just have a free flow. This is what we're doing all the time as homeopaths anyway. Do you see how well prepared we are to have these kinds of conversations with clients? And then occasionally we give them open-ended prompts. Tell me more about, can you tell me more about that? Or a lot of times what I like to say is there more to say about that? I think that's a very gentle, neutral phrase. Is there more to say about that? Okay. And people very often, one of the things that we as practitioners are going to have a tendency to want to do is to try to make a linear timeline. We're trying to figure out, did this happen before that or after that or what? And so we're going to we're going to want to step in and ask, that happened before, when, I'm confused. Nah. When we're dealing with trauma, leave all those things till later. Just listen. Don't worry about sequence, about narrative, about any of that. And then ask, can you share with me what you were thinking, what you were experiencing? And for this particular client who got shot, there was the trauma of getting shot out of the blue, and then there was the trauma of being in the ER, having the bullet taken out and dealing with all of that stuff where they were asking her if she'd been dealing drugs and they were accusing her of all kinds of things. Nobody gets shot at random. The police came and interviewed her and, they wanted to know if there was a reason why she had been shot. What was she up to? And so she was a suspect. So all of this is very, very difficult. And people will talk about things like being frozen. I was paralyzed. I was frozen. I was rooted to the spot. I couldn't move. We know there are great remedies for this. I've had times where I've grabbed out some stramonium or some opium and put it in a cup of water and give it to them while they're sitting there talking. So don't think that you can only give the trauma remedy later after you've figured out the case. Think about, you can almost always give them arnica. You're not going to hurt anybody with arnica. Have any of you guys done this where while somebody's there talking about whatever their trauma is, you give them a dose of Staph aureus, you give them a dose of arnica or opium or some other kind of vulnerary? You need to make sure that if you're going to be working with these kinds of cases, you have those remedies available. Myra says just flower essences. And the flower essences help, don't they? It helps people, yeah. Okay. And then you help people bridge from their experience into sensation. Oops. Excuse me, I have a tickle. Yeah, Myra says she just has this in her office and she just gives it to him. Great. Okay. So sensory information helps you identify details. And, you know, cops and other people who are doing interviews are looking for facts that juries can use. I want you to think about the jury of rubric court. These kinds of details, sights, smells, sounds, they will help you get into the detail that will help you repertorize the case effectively. We tend to say, oh, well, it was a rape case. They need staphysagria. Well, maybe they do and maybe they don't. There are a lot of different adaptations to rape. And so we have to look at what was the specific thing for this client. How are you guys doing? It's kind of quiet out there. You okay? Anybody that's left the room, please take a minute to breathe. Feel your feet on the floor. Feel your back against the chair. Okay. I want to make sure you're okay. Ask the person how this has affected them. And to me, this is the most useful question. How are you different physically? How are you different emotionally? How are you different experientially in your life because of having gone through this experience? This is where we're asking them basically to show us what's the adaptation of the constitutional state. So, for example, if you have somebody who was raped who becomes very promiscuous, that's going to be different than, you know, somebody who's Nat Murish and decided to become a nun. Or I've had clients who, and I saw this several times in San Francisco, where someone who had been molested or raped then said, that's it, I'm not dealing with guys anymore. I'm going to partner with women. Because I'm going to work with women, I'm going to play with women, I'm going to partner with women because I am done with testosterone. And it's an adaptation, it's not a choice. They see it as the only possibility to being lonely forever. Okay? So all those are very specific types of adaptations. And then ask, what was the most difficult part of the experience? And what can you not forget about the experience? And these help us see where is the person stuck. And then we can move from that information into a way of looking at the case with them. Okay? So I want you to read over this whole document, put it in your clinic reference notebook, keep it somewhere where you will be able to reference it if you need to. If you know that you have a consult coming up that's going to be kind of hairy, like I knew the lady who had been shot who was coming in, I knew she'd been shot, I knew she'd been to the ER. So it would have done me good to be able to review this before that happened, before my consult with her. Okay, so let's go back to our presentation document. Okay, so those little guidelines, print it out and practice it. Make notes, practice, pretend, role play with somebody else, practice. If you don't practice, your tendency is going to be to react instead of be proactive. And it will be much harder for you to be in professional mode. And look at what your own experience is to get clear. If you have your own trauma history, deal with it. And then some of you may be familiar, are you guys familiar with Dr. Pennebaker from SMU, Southern Methodist University, and his work that he did to clear trauma? Are some of you familiar with his stuff? He asked students, he did research with students where he had them come in for 20 minutes, 5 days in a row. Pennebaker, it's on the screen here, Pennebaker. That's okay. I know some people are dialed in on the phone and they don't see what's going on the screen. Pennebaker did research where he talked about the value of reflecting on your traumatic experience, your own, and a way that you can let the light in through the broken places yourself instead of looking to somebody else to fix you. And so I assign this to my clients very often. So what he suggests and what he did with students is that you have them come in and for 20 minutes, 5 days in a row, they're to write about the most traumatic, difficult experience they've ever had in their life. And the first day they write about it, there's all this pain and tears and sobbing and bother, and it's difficult. And the second day they come in and it's not quite so difficult. And the third day they come in and they're writing about the same thing day after day. The third day they come in and it tends to be more of just a rote rehearsing of the facts again. And by the fourth day, very often they're starting to introduce third person ideas and actual reflections. Oh, I can see now because I had that experience, this is what happened with, or my ideas now about are. And by the fifth day, almost everyone expressed some level of gratitude for having gone through the experience because they had reframed and in some way healed the trauma. Not necessarily completely, but to some extent. And sometimes people have to write about this again and again. I have clients who really avoid doing this. They refuse to do it. And when I finally get them to do it, it benefits them almost 100%. So very often when somebody's had something difficult, this will help. So I want you to do this for yourself. And I'll include some documentation about Pennebaker's work with this recording when I post it. Another thing that I want you to think about is, can you volunteer for a helpline? A suicide crisis helpline, a rape crisis helpline, a domestic violence helpline. You will get incredibly valuable training. And you don't have to be on the phone anymore. They have text or online chat messaging hotlines. And so if you're interested, you can go through the training and you can find out what's going on and work with that. It will help you a lot. A lot of times they'll say, okay, if you do the training, we want you to commit to a year of service. And believe me, it will completely alter your perspective. Have any of you done this? Can you share a little bit about it, Dot? About what the kind of program you volunteered with was and how it helped you as a practitioner? I established the first sexual assault center in a Canadian university in 1991. All right. So you're familiar with all of this. Is there something that you would like to add to what we've talked about today based on your experience? She says, I think just being truly present to the person who's before you with your heart open, being there in that I, thou place instead of I'm here as the helper and you are clearly the victim. That's not the same as being present, is it? Because that puts us into the role of you're the broken person and I'm the fixer. And as soon as you become the fixer and they become the broken person, you are now in an I-it relationship. Okay. Is there anything else? Any other comments that anybody else has about this? Do you feel prepared now? Do you have a few resources to help you refine the way that you interact with some of these intense circumstances? Okay. All right, guys. Best wishes to all of you, and I'll see you at another class in the future.